Hi, Dr. Bilsky.
Hi.
Hi. For those watching today, I am Alexandra Larsen. I am the Chief Resident in Neurosurgery at Memorial Sloan Kettering and Cornell, and I have the distinct honor of interviewing you, Dr. Bilsky, for the FAANS Leaders in Neurosurgery series. Just to give you an introduction that you so deserve, Dr. Mark Bilsky is the William E. Snee Endowed Chair in Spinal Oncology, Vice Chairman of Clinical Affairs of Neurosurgery, and Chief of Multidisciplinary Spine Tumor Service at Memorial Sloan Kettering Cancer Center in New York City. Dr. Bilsky attended University of Michigan for college, Emory University for medical school, New York Hospital Weill Cornell Medical Center for residency, University of Louisville for fellowship, and has been a neurosurgeon at Memorial Sloan Kettering his entire career, since completing neurosurgical residency and spine fellowship in 1995. He specializes in primary and metastatic tumors of the spine and spinal cord and is a foremost authority in the field of spinal oncology. It is a real true pleasure and honor for me to be able to discuss your significant contributions to the field of neurosurgery and spinal oncology for the FAANS Leaders in Neurosurgery series.
Okay, Alexandra, thank you for that incredibly kind introduction, and also for being just an incredibly spectacular resident and friend. And thank you to the FAANS for putting on this series and allowing me an opportunity to discuss what has been an incredibly meaningful career over the last 30 years.
Great. So we'll start with your childhood in Memphis. So growing up in Memphis, you credit your parents with setting a precedent for giving back to the community in a meaningful way. Can you speak about your childhood and early medical exposure in Memphis that helped set you on this trajectory?
Yeah, thank you. So my father was a stockbroker, and my mother was a middle school teacher, went back and got a PhD, ran the computer curriculums for the Memphis City schools, and then went to work for Apple for the last 10 years of her career. And they were two of the most philanthropic, giving people in the community. Their house was open to everybody, and they really set a precedent for how to meaningfully give, again, to a community that was really important to them. The Memphis community also had an incredible medical presence. So we had Sims Murphy in neurosurgery at Campbell's Clinic in orthopedics. And one of the orthopedists, Larry Morrison, took an interest in me and got me a job as a scrub assistant at Baptist Hospital in Memphis, which I did for all 4 summers. And it was an incredible experience of being really comfortable in that environment. So by the time I got to medical school, I had spent countless hours in the operating room, and I think I'm maybe the only neurosurgeon who still knows how to tie a one-handed surgeon's knot. And it's a pretty useless skill. It's a good party trick, and then you have to ask what party would you use that at, and I can't really tell you. But again, just sort of a really meaningful experience being in Memphis with that incredible community.
That's amazing. Your parents sound like wonderful people.
Incredible.
So as a student at the University of Michigan and Emory for medical school, how did your interest in neurosurgery and oncology begin?
Yeah, I think so many things in life are just serendipitous. And I was taking a neuropsych course at Michigan and had to write a paper, and I was running through the stacks in the medical school library and came upon Mystery of the Mind by Waddell Penfield, which is his experience in trying to explain the mind-brain dichotomy through intraoperative mapping. And I thought that was the most interesting question in the world, and something I absolutely thought that I would, if I ever went into neurosurgery, would certainly be my biggest interest. And of course, it sort of passed out of my purview, but it was sort of the initial interest in brain for sure. The second experience was really interesting. I had a organic professor, Seyhan Egi, who was the first full tenured female professor at the University of Michigan, and just an incredibly powerful, brilliant force. And she had a friend who had colon cancer that had invaded the sacrum. He had this mass on his back. And she recruited me and then many students to sort of help with this holistic approach to the cancer. He'd failed all medical therapy. There were no surgical options, and so they went on something called Gerson therapy, which is a way of trying to boost the immune system to fight the cancer. And of course, it didn't work, and we watched him over the course of the year have this incredibly painful death. But it really piqued my interest in cancer and in taking care of cancer patients. And the 3 things I learned from that, I think, first was they used a lot of juices. One was liver carrot juice, and even if you put carrot in liver juice, it's still disgusting, and I think we can all admit that that doesn't sound great. But the other things that I really learned from that experience were that the medical therapies and surgical options we had at the time were not very effective, and we had a mandate to make that better in some way. And the other thing was that even if you couldn't cure somebody, there was a massive role in palliation, and sometimes the best you can do is show up for a patient and be there for them. And I think that lesson with him probably stood me in good stead in terms of how we approach the spine tumor patients, the metastatic patients particularly. It has really was a great lesson at the time, and I think it's the way we approach them to this day, is you have a mandate to make it better and then to be there for them.
Absolutely. Yeah. Well, that's a great transition to the beginning of your career at Memorial Sloan Kettering, where you spent your entire career since 1995 and are quite the legend within these walls. So when you started out at Memorial Sloan Kettering, you were actually called back from spinal fellowship early due to the other neurosurgeons leaving the department. And you started as the only neurosurgeon in the department with an initial interest in cranial and skull-based malignancies. Looking back on that time, which I think not many of us will have that kind of experience, how was that experience and how did it help shape your career?
Yeah, it was a little bit of a turbulent time. I think the interesting thing was that I was a month away from finishing residency and had a job at Memorial, and they had a need to grow out a spine program. And so with a month to go to finish residency, they asked me to go find a fellowship. And by the grace of goodness, they took me at University of Louisville, which was one of the early programs to take neurosurgeons and treat them and teach them spine instrumentation. And so by the grace of goodness, I had great training there. Then when I came back to Memorial, both neurosurgeons had left. What is amazing about a cancer hospital is that they just envelop you with this infinite amount of knowledge and wisdom and experience. And so I was the only neurosurgeon here, but I had such support from every single person in the institution. The most important were probably certainly Jerry Posner, who's the father of neuro-oncology, and he gave me a tutorial every single day. And we tell that story about he came, there would be a note on my door and he'd say, "Come see me," and I would go to his office and he'd put up a film and he'd say, "What do you think?" And I'd tell him what I would do, and he'd say, "No," and then he would tell me the story and tell me why I was wrong, and then I would go back the next day and he would put the same film up and say, "What do you think?" And I'd say, "What we said yesterday," and he'd say, "No," and he would tell me a different story. And it was this real lesson about there's a global assessment that has to come to play with these patients, not about the imaging solely. And so I sat at his feet for really a year and a half before Phil Gutin came and really became my chief, but it was an incredible experience. And then we had an experience with orthopedics, particularly Pat Bolin. They were just superbly good at bad bone. They just had this innate ability to fix anything. And one of our original cases, we did spine together early on, and we put an L2 femoral graft in and compressed the Z-plate down, and the Z-plate came straight through the bone. And so we changed a 1-level problem into a 3-level problem. And there was no panic. He's like, "Oh, I can fix that." And there was a brilliance in how to deal with pathologic fractures and bad bone that was just, got us so far ahead in how we thought about it and how we could deal with those problems. And then I had a big cranial-based malignancy practice, really with my partner, Dennis Krause, who was one of the really, again, foremost authorities in that. And we developed sort of a massive program. And then ultimately, when Phil Gutin came, he had a need to grow out a spine program. And so we sort of transitioned over completely. But they taught me more about, cancer and how it is not wholly a surgical problem, that there are these, that it has to be ultimately multidisciplinary. And then as time went on, we got better and better adjuvant therapies with radiation, and then certainly systemic therapies have progressed so significantly in the last 10 years, and all of that comes to bear on what we ultimately ended up doing, which were the spine tumors.
They sound like incredible mentors, and what a beginning of your story. So transitioning to spine oncology, which you're well known for around the world, you've defined and transformed the landscape of spinal oncology, including the Bilsky epidural spinal cord compression grade, separation surgery for metastatic spinal tumors, NOMS decision-making framework for spinal metastases, and the development of multidisciplinary spinal oncology programs involving radiation oncology. Starting with NOMS, what was the inspiration behind developing this decision-making framework?
Yeah, NOMS ultimately became the cornerstone of multidisciplinary care. Where it really started was we were just looking at this incredibly complicated patient population and had to make sense of it in the context of what we were seeing. So early on, we had decision-making frameworks or algorithms, the Tamita and Takahashi score, but they didn't really address what we were seeing, which was they were really interested if you had oligometastatic disease, you would be recommended for non-block resection. Everything else went to radiation. And what we were really seeing were patients coming in with significant fracture-related pain or high-grade core compression with neurologic issues. And oftentimes these patients would come in with obviously multiple medical comorbidities and then a lot of oncologic issues. And oftentimes with thousands of patients, or thousands of pages of records, and it was a matter of trying to pull out the sentinel decision points that you could actually pull out and make very consistent decisions, and that's how it ultimately started. And we started, I think we wrote our first paper on NOMS in 2004, and then ultimately what we did was every new technology that became important or evidence-based medicine, we could simply integrate into the same framework. And so it's been a very consistent framework, although the decisions we made in 2004 are very different from the ones we do today. And we try to update NOMS every 2 years, again, with these newer technologies or newer evidence-based medicine that really, again, usually not incrementally, but exponentially improves, patient outcome, and in the context often for metastatic disease of being effectively palliative, with limited morbidity.
Wow, that's incredible. And it is a very clear framework when you look at the paper, and it's a true algorithm that you follow. When you get a consult in the middle of the night, it's really revolutionary.
Well, for the residents, I think sometimes they'll start with a preamble of, and then you just say BL. I only need to know 4 things to make a decision, and on we go, because it really, it sort of comes down to that at the end. Yeah.
That's great. So moving on to one of your other major contributions, for separation surgery, you often mention the goal is to make the technique straightforward enough so that it can be done in neurosurgical programs and hospitals around the country and not require a specialized neurosurgeon, spinal oncologist. Can you comment on this goal and how the technique has evolved?
Yeah, I think at the end of the day, spine tumor surgery, especially for metastatic disease, should not be proprietary to ivory towers or cancer centers, that everybody has to be able to take care of this population in a really meaningful way. When we got radiosurgery as a postoperative adjuvant, could give ablative radiation, all of a sudden it didn't make sense to do either en bloc resection or even intralesional gross total front back, and the vast majority of these patients will not tolerate an anterior transcavitary approach. And so simply doing a decompression from posterior with a simple posterior fusion, which in this day and age every neurosurgeon orthopedic can do, was really meaningful, that you could provide very timely care in your institution and have the same outcomes as we do here, where this technique and the philosophy of simple separation surgery followed by radiosurgery, what we call hybrid therapy now, sort of took shape. And it is so meaningful because, again, it was never about Memorial or creating something that would only be done here. It was about this cancer community that we are so responsible for across the world and making it better for them. And so we're thrilled not only that everybody can do this. I think certainly in New York, it can be done well by virtually every institution. But we started to create these multidisciplinary programs in institutions that traditionally have been very surgically heavy. So, Ohio State, Vikram Chakravarthy and Josh Palmer are there, in Seattle, and Simon Lowe are there. And they get this concept of this coordinated care that, again, reduces morbidity in this population, but is incredibly effective at getting control of tumor, preserving neurologic function, and then getting them back to early systemic therapy very quickly.
And these individuals you mentioned, these are your fellows.
Yeah.
So, I mean, that's quite the legacy to be able to train spinal oncology, neurosurgery fellows, and then have them go out and build programs in these other institutions.
Indeed, yeah, exactly.
So how did you build out this multidisciplinary spine tumor team model? We know you're very close with your colleagues in radiation oncology and physiatry and physical therapy, and really have created for the patients and also, to optimize their care, this true multidisciplinary model.
Yeah, it's interesting because when I got to Memorial, Jerry Posner had defined the role of conventional external beam radiation, and the institution was wedded to that. They'd gone through a period of very aggressive surgery, and the outcomes were really poor. And with laminectomy compared to conventional external beam radiation, there's really no difference in outcome. And so the least morbid thing was to irradiate. And if the patient got irradiated and failed, we would take him to surgery. By about the mid-1990s, with improvements in surgical technique and the development of segmental fixation, and then the Patchell study, 2005, showed that surgery was better than conventional external beam radiation. There was this proliferation of incredibly aggressive surgery. In a way, it made sense because conventional external beam radiation wasn't very good at controlling tumor in the postoperative setting, and so the more tumor you took out, the better chance you had of controlling the tumor, at least for durably for God willing, a long life, but certainly for the life of the patient. Around 2004, 2005, we got stereotactic radiosurgery, and what you realized was that all those patients that got conventional external beam radiation and failed weren't coming back with failures, and that signal happened right away. We knew it right away. And in point of fact, I was doing about 120 tumors a year by that point. We got SBRT, the earliest iteration. My volume fell to 40 because nobody progressed and needed surgery. And it was at a period in time where I had sort of already given up cranial-based malignancies to concentrate on spine, and then they all of a sudden took spine away from me too, and I thought, well, the only thing that's really important is to be able to make a contribution in cancer, and maybe the contribution is we introduced radiosurgery, and that solved that problem, and I'll go find something else to do. And in point of fact, at that point, the institution actually increased their catchment dramatically, and so our volume went up. We were a very late adopter at Memorial in intracranial SRS, but we were a very early adopter of spine radiosurgery, driven by Phil Gutin in part, who had a big experience in the brain, and then Steve Leibel, who was the chairman of radiation oncology. Phil had a need to develop a spine program, and he had hired two brain people who were labs, so Vivian Tabar and Cam Brennan came back. And I didn't really have a role in the lab, which is where the cure for brain tumor malignancies was going to come from. And so he just looked at me and said, "You're the spine guy." And at the same time we got interested in radiosurgery, they had a prostate guy, Josh Yamada, which was really the first application of IMRT, and they said, "You're the spine guy." And so all of a sudden, two people who didn't know each other got put into a group. And the third person was Eric Liss, who is the best neuroradiologist in the world, the best spine reader in the world, and a frustrated car mechanic, and he became our interventional radiologist. And we just happened to have this interest coalesce at the same time. We sort of got tasked with being spine, we got SRS at the same time, and it was the very beginning of kyphovertebroplasty. And so we joined a group because we didn't really know the answers to any of it. It was the very nascent of trying to integrate this new technology that we knew was going to be important, but we ultimately had to sort of figure it out as a group. And there were a number of other groups that formed around the same time we did with stereotactic radiosurgery. The difference is, I think in 30 years, I'm not sure we've ever had a crossword with each other. It is the most cooperative venture. Again, it was just kind of luck of the draw. It was just three people who had infinite respect for each other and trusted each other's judgment. And we have built this program out over the last 30 years. And now there are probably about 30 people who are integrated on a daily basis and so it's sort of taken on a life of its own, but it really started with three people who had a real mandate to figure something out with new technology. We've written a little over 250 papers now, and we try not to write incrementally important papers. We try to do stuff that exponentially moves the needle or proves a point that needs to be incorporated into the spine tumor milieu. So it's been a real incredible labor, and again, we've even on the surgical side, Ilya Laufer was here and he was superb, and then Ori Barzilai and Chris Newman are here now, and they all have very specific surgical interests in MIS and robotics, and very specific research interests that continue to expand how we approach these tumors and make it meaningful, again, for this incredible cancer population that we get to take care of.
Wow. That's incredible. And knowing you, it was a true labor of love. Transitioning to one of your other loves, your patients. You have an extreme dedication to patients and to the alleviation of suffering. As a resident working with you, one example really stands out. We received a non-operative spine consult overnight for a very sick patient that was in a lot of pain. When the resident and fellow team rounded the next morning, the patient mentioned that you had visited him in the middle of the night and had already discussed the plan with him. When I asked you, why did you come in the middle of the night, you answered, I did not want any time to go by where he thought that we did not care or take his pain seriously. And that was really such an influential conversation. You have demonstrated a true love for and dedication to patients who are terminally ill and really suffering from horrible, horrible pain. Can you speak about your relationship with your patients and how you have cultivated this lifetime of service to others?
I think everything, all those experiences that we had early on sort of culminated in a dedication to this incredibly resilient and amazing patient population. I am so honestly blessed to have been able to be here and then to be able to service this population. And it has been the great privilege of my life. I think the other thing that was really important in service to this population in terms of saying non-operative is that because we had such an integrated program and we have multidisciplinary clinics where all 4 services, or we've now added pain and physiatry to that service, goes to the same workspace at the same time with the same patient population. And so it gives us the opportunity to see our successes and failures in every domain. So a lot of times if you're a surgeon, you become a numerator doctor, you only see what comes to you that may or may not require surgery. When you see the spectrum of what goes to radiation or IR or neurosurgery, and you're able to, again, almost in real time, see what worked and what didn't work, it is a completely multidisciplinary coordinated effort to be able to do that. And that's what we bring to bear for these patients. I think in part, and I'm not the, I really love what I do, but so does everybody else in this program. And so, the ability to coordinate that effort so that even if a patient comes in to spine clinic, for instance, and it's not neurosurgical, we have the ability very quickly to get radiation oncology and our IR to come in so that we expedite treatment care and then, facilitate them getting what they need as quickly as possible. So everything we have done is in service to taking care of this population. I think to a large extent, early on, even in cancer hospitals, if you couldn't cure somebody, then you didn't have this need or mandate to treat. And it goes back to that real mandate in the metastatic population to provide palliation, and that means being there in the middle of the night. If somebody just needs somebody to talk them through that and know that they'll be okay, we'll take care of them.
That's wonderful. So looking back on your career and your legacy, especially revolutionizing and establishing the field of spinal neuro-oncology, what are you thankful for?
Yeah, I'm so thankful that we were able to contribute in a meaningful way to the advancement of metastatic and primary tumor care, and I think it has been incredibly meaningful for this population. I'm very thankful that I have a wife and a daughter who have been incredibly supportive of this venture because I wasn't home a lot, and they went on about their lives and supported me in every possible way. It was very helpful that my wife, Christina, is a nurse who worked here and understands this population, and my daughter is now finishing ENT residency and going to do pediatrics, and so she followed in both of our examples of again, how to live a meaningful life in this field. I think what is really amazing is that I have seen a lot of people come through Memorial who are incredibly famous surgeons and incredibly dedicated to this craft. And 2 or 3 years after they're gone. The memory of what they did was gone, et cetera. And it's the way it's supposed to be because we built our legacy on the shoulders of giants, and then people will take this legacy and continue to grow it in a meaningful way that will make us look obsolete in a few years. And it's exactly as it should be. Somebody laid a foundation for us, we laid a foundation, and so I'm really grateful for that. And I think at the end of the day, I hope I'm a footnote with an asterisk, and the asterisk is that we did something important at a point in time and then it moved on.
Thank you, Dr. Bilsky, for sharing all of that with us. You have a truly incredible career and have dedicated your entire life to helping others in some of their worst moments. On behalf of all the residents and fellows and now attendings that you've trained, thank you. And you have truly led by example and have established in our minds exactly the type of surgeon that all of us aspire to be.
Thank you in equal measure. I think you are extraordinary, and I can't wait to see the rest of your career.
Thank you.
Thank you.